All right, let's take a look at Chapter 9. This is Diseases of the Circulatory System. Those of you that are familiar with ICD-9 know that we do have several guidelines out of this chapter. Thankfully, some of them have not changed. Some are a little bit different. So these are our I codes, I00 to I99. Alright, so a couple changes is that we don't have any hypertension table anymore, and the reason for that is that we don't have any designation of malignant hypertension or benign hypertension. This is another one of those changes in 10 that I think is an improvement because in my experience, physicians don't document whether it's malignant or benign anyway, so it was very often that we had to take the code out of the unspecified column. So now we've gotten rid of that. So since we don't have the separate columns for malignant, benign, or unspecified, we don't need any sort of a table anymore. So when we look up hypertension in the index, it's going to look very similar to what it did before. It's just that we'll get one single code instead of having to choose from 3 different ones. Alright, and again, those of you familiar with 9, remember our hypertension guidelines. Thankfully, they are exactly the same in 10. I guess I say thankfully in that we don't need to learn new ones, although they still are kind of just as confusing as they used to be. Okay, so when we talk about hypertension, we can also have hypertensive heart disease, renal disease, both or neither. So we'll kind of talk about each one. So hypertensive heart disease is category I11. So remember with hypertension and heart disease, it has to be stated that there's a causal relationship. So notice in my title here I have hypertensive heart disease, or we could have hypertension or heart disease due to hypertension or something like that. We need some sort of causal relationship to be stated in order to code out of the I11. So our examples here, we have hypertensive cardiomegaly, and then we have cardiomegaly with hypertension. This one indicates causal, that the cardiomegaly is happening because of the hypertension. Here, there's no causal relationship. So in this case, the top one we would code out of the I11 category. This one we would code cardiomegaly separate, and then we'd code hypertension, which is out of the I10 category. If we have hypertensive heart disease and it indicates heart failure, we still have an additional code out of the I50 category to indicate the type of heart failure. And I'm just going to flip over to my tabular here real quick and we can just take a look at these categories. So hypertensive disease, we're in I10 to I15. I10 again is just basically hypertension. Notice it includes both malignant and benign now, also essential, systemic, all of those different non-essential modifiers. And notice that there are no additional digits. So again, this is one of those codes that's fairly easy to remember. I know most of us probably know 401.9 if we're familiar with ICD-9. In ICD-10, it's I10 is our new kind of generic hypertension code. So if you want to say you've memorized an ICD-10 code, there you go. So we just talked about I11, hypertensive heart disease, and then notice if we have with heart failure, we want to use an additional code to identify the type of heart failure. Without heart failure, we just end up with the I11.9. Alright, hypertensive chronic kidney disease, again, same guidelines as we had with 9. This one actually assumes that there is a cause and effect relationship, so we don't have to have that causal statement indicated. So whether this read hypertensive chronic kidney disease or hypertension with chronic kidney disease, we would still code both of those out of the I12 category. So unless it specifically states that the kidney disease is not due to hypertension, we are going to code this out of I12. Just like with the hypertensive heart disease, we're going to use an additional code to specify any stage of chronic kidney disease. So here's that I12 hypertensive chronic kidney disease. Notice use additional code to identify the stage of chronic kidney disease. And here, because they're both with chronic kidney disease, you have to use it with either. There is no hypertensive chronic kidney disease without chronic kidney disease. So both of them you have to use something out of the N18 category. This is the I12.0 is if we have a stage 5 or end-stage renal disease. I12.9 is if we have stages 1 through 4. So here's our example, hypertension with chronic kidney disease. Even though there's no causal relationship, we still code that out of the I12 category. And then the last category of kind of these specifications, we have hypertensive heart and renal disease. So this is category I13. So it's the same rules. To indicate the heart disease, we still have to have a causal relationship. We still assume a causal relationship with the renal disease. So our example here, hypertensive cardiomegaly. So there's cause indicated here, and hypertensive renal failure. So in this case, rather than getting I11 and I12, I just get something out of the I13. I still need to add additional codes if I have heart failure, and then I also need an additional code to indicate the stage of chronic kidney disease. Now, if this read hypertension with cardiomegaly and renal failure, I would assume the relationship between the hypertension and renal failure, but not the cardiomegaly. So in that case, I would end up with hypertensive renal failure. I would get something out of the I12 category, and then I would code the cardiomegaly separate. Couple more areas with hypertension. We have hypertensive cerebrovascular disease and hypertensive retinopathy. Just kind of a heads up that you do need two codes here. So here we'd have the cerebrovascular disease and the hypertension. Here, even though this reads hypertensive retinopathy, you still code the hypertension in addition to this H code. And then your sequencing is going to be based on their reason for the encounter. Are they treating the retinopathy or are they treating the hypertension? And then I always mention pregnancy, so remember that your pregnancy codes take precedence. So we have O10, something out of that category for some sort of pre-existing hypertension in pregnancy, as opposed to preeclampsia. And then here you could have an additional code to specify the type of hypertension. And then also secondary hypertension, similar to secondary diabetes, it's hypertension that's caused by some other disease. And here, again, two codes required. So you're going to typically code your underlying condition first, and then your secondary hypertension after that. So here's acromegaly with secondary hypertension, so I'm going to code the acromegaly, and then I'll code something out of that I15 for the secondary hypertension. And you can find this just hypertension as your main term and then look under secondary as a subterm. Some other just kind of comments with hypertension. If you see transient hypertension or elevated blood pressure in the documentation, we're not going to assume that that is hypertension. So we actually end up using a symptom code here that just basically says they have elevated blood pressure, but they have not yet been diagnosed with hypertension. And if it's gestational hypertension, again, we're getting that out of the obstetrics chapter. There aren't any codes available to describe controlled or uncontrolled hypertension. I know that's some terminology that I have seen in the health record. So whether it states controlled or uncontrolled, you're just coding the regular I10, or if they had some sort of renal or heart manifestation, then of course you go into categories I11, I12, or I13. All right, this is a change, another one that I think is an improvement in ICD-10, and I think I briefly talked about this in another example. Atherosclerotic coronary artery disease or arteriosclerosis, you'll read it either way, and angina, we now have combination codes. So here you can see I25.11, atherosclerotic heart disease of native coronary artery diseases with angina pectoris. Here's I25.7 is atherosclerosis of a bypass graft, transplanted heart with angina pectoris. So in ICD-9, we used to get two codes there. We'd have one for the CAD, one for the angina. Now we have a combination. And here we can assume a causal relationship. If a patient's admitted with coronary artery disease, is admitted due to an MI, then you actually are coding both of those, so you can code the acute MI and the coronary artery disease. And a quick note on this slide, because I know it comes up in one of the practice questions, but I don't have it written in a slide. Remember that if your record indicates coronary artery disease and there is no indication that there is a history of a bypass graft, we can assume that that is of a native vessel. Sequela of cerebrovascular disease, we did talk about this a little bit when we looked at late effects. So it's category I69. So again, this indicates both the deficit that remains and then the fact that it is a late effect of that CVA. I also wanted to point out just if there's a history of transient ischemic attacks or TIA, Or if there's a cerebral infarction that doesn't have any sort of residuals, then we code that with Z86.73. All right, this is the main section that I would say is a change from ICD-9. So this is where those of you that know 9 might have to kind of make some adjustments in what we used to know about coding these. The acute MIs they're still ordered between STEMI and non-STEMI, and then based on the actual location of the MI. We do have a new guideline that we can assume it's STEMI if it doesn't state otherwise. So again, these are an ST elevated MI versus non-ST elevated. These are going to indicate a complete blockage in that coronary artery. Coronary artery. The change here, we have a change in weeks. So our acute MI is now 4 weeks. So we have to kind of adjust that timeline in our minds, those of you that know ICD-9. And then we also have basically now we have the initial MI, and then we have a subsequent MI. So your initial MI is going to come out of the I-21 category. And let me just scroll down to that really quickly here. So here's I-21, ST elevation or non-ST elevation, STEMI or non-STEMI MI. And here and then we get down into our subcategories and subdivisions to indicate the exact location of that. So notice here it's MI specified as acute or with a stated duration of 4 weeks, 28 days, or less from onset. Now, if the patient has what is now termed a subsequent MI, so if they suffer another myocardial infarction within the 4 weeks from that initial, then we're going to code that out of the I-22. So it used to be that we would just code both of them as basically a new acute MI, a myocardial infarction. Now we have the initial coded out of I-21, and then if they suffer another one, whether it's in the same location or a different location, within that 4-week time frame, we're going to consider that a subsequent MI, and we're going to code it out of the I-22 category. And we'll take a look at that here real quick. So we were in I-21, just going to scroll down. Here's I-22, subsequent STEMI or non-STEMI myocardial infarction. Notice acute MI occurring within 4 weeks from a previous MI. And these need to be coded in conjunction with an I-21, because if we don't have an initial MI, we can't have a subsequent. So we need to code both of those together. Now that doesn't mean the I-21 is always going to be sequenced first. If a patient suffered, let's say they suffered an MI 3 weeks ago and everything was fine, they were sent home, and then they were admitted again today with a new MI, well, it's the subsequent MI we're going to be dealing with in terms of treatment. So we would sequence the I-22 first, but we still want to code the I-21 to indicate that there was another MI that occurred within the last 4 weeks. We do still have our old MI code, this I-25.2, and basically that's just to indicate a healed MI. Alright, so here's a practice one. This one's fairly basic. We do have a cross-reference. I do have an MI practice question on the coding practice online. That one is probably a little bit more challenging than some that we've done, so do your best on that one, and then I have put the answer in there. So if you have any questions on that, just let me know. So right now we'll take a look at the mitral and tricuspid valve disorder rheumatic. Alright, so I'm going to go over to my alphabetic index, and again, because I have a ton of scrolling, I thought I would just kind of jump down here. So I went to disorder as my main term, and then down to valve heart is right here, and I'm on page 449. And then it is rheumatic, and we have mitral and tricuspid. So notice here I have C, endocarditis mitral, C, endocarditis tricuspid. So I'm going to scroll down to that, and again, I'm just going to scroll pretty quick because I already looked this up and I know what page number it's on. There were 100 occurrences of endocarditis, so I thought I would try to go a little quicker. Okay, so here's endocarditis on page 500, and then we're going to scroll down till we get to mitral. Here's the mitral, and then and here's tricuspid disease. Now notice we didn't see anything with rheumatic yet, but we'll take a just double check. We're going to go to I08.1 in our tabular. I'm just going to page up to that. I'm already pretty close. So here's I08.1. Rheumatic disorders are both mitral and tricuspid valves. So we've captured mitral and tricuspid valve disorder, that it's rheumatic, and we got I08.1.